Okay, so welcome back to this next video in which we are discussing endometriosis. Okay, so we're currently discussing the seventh place that endometriosis can occur, which is the mucosa of the cervix. Okay, so we've discussed that at the cervix you have this transition from the squamous epithelium of the vagina to the columnar epithelium of the cervix, okay? And the cervix is a mucosa, basically. It secretes mucus, so it has these invaginations from the surface which go down and form these tubes here, which will be secreting mucus, and then the mucus will go through their lumen and then be secreted onto the surface of the cervix, okay? So these are cervical glands. Okay, right. So let's just label this up now. These epithelial cells here are columnar epithelial cells, okay? And those are the normal epithelial cells that you would have on the cervix, okay? And then the epithelial cells that you have lining the vagina, these are squamous epithelial cells. Okay, so you have a transition basically between the squamous epithelium and then the columnar epithelium, and this is what's known as the squamo-columnar junction. Okay, so we can see it shown starkly here. It won't be quite that starkly, it will occur more gradually. So this is the squamo-columnar junction. Okay, right. We've now talked about the 7 places that endometriosis can occur. We've concluded with this cervix, and basically if you have endometrial tissue in the cervix, that is a form of endometriosis. Okay, so let's now talk about the 2 theories of how endometriosis occurs. So one of the theories is what's known as the metastatic theory, okay? And this basically is the theory that tissue from the endometrium moves from the place that it should be to the ectopic location. Okay, so you have the metastatic theory, and this basically is the theory that you have tissue in the endometrium where it ought to be, and then if it moves from there to the new location somehow, maybe through the blood or maybe via retrograde menstruation, and I'll just talk about that for a moment. So when menstruation occurs, when the functional layer of the endometrium is shed, what can sometimes happen is the shed endometrium can go the wrong way, basically. Rather than passing through the cervix and then out the vagina, instead it can go up the fallopian tubes, and that's potentially how this endometrium can then end up at the ovaries and potentially in the pelvic peritoneal cavity, basically. So retrograde menstruation. And retrograde menstruation is actually extremely common. It's not a rare phenomenon, okay? So often when menstruation occurs, you do get a little bit of endometrium going the wrong way. You do get a little bit of retrograde menstruation, so it's not a rare thing. And the idea is that potentially this could lead to the movement of the endometrial tissue to other areas. Alternatively, it could go via the blood, basically. It could go into the blood, and then it could disseminate to some of these other locations as well. But you don't generally see endometrial tissue going particularly far from the female reproductive system, so that suggests that maybe it isn't through the blood. Okay, but the metastatic theory, in principle, what it says is that the tissue from the endometrium ends up moving to this new location. That's the metastatic theory. There is also the metaplastic theory. Okay? Now, the metaplastic theory says no. It's not that tissue from the endometrium has moved to this other place. It's that this tissue at the new place has become endometrial tissue. Okay, so it has differentiated just bizarrely. So basically, you had this tissue at this alternative place, and it's not that you brought endometrial tissue from the endometrium to to there and then dumped it there, and then that's the endometriosis, that's the metastatic theory. Instead, the tissue at this new location actually became endometrial tissue. Okay, so it's the fault of the new place, basically. The new place has become endometrial tissue. Okay, that's the metaplastic theory. Now, basically, the metaplastic theory has been largely discredited. It's just not widely accepted at all. The metastatic theory is the general theory that most people would accept is what probably actually happens in endometriosis. But we don't actually know. Okay, so we will work then on the metastatic theory because that's the most widely accepted. So we want to know, why does the endometrial tissue that gets deposited at this new ectopic location, how does that survive? Because endometrial tissue doesn't survive very long. Usually it is menstruated, basically, it dies. Okay, so what allows this endometrial tissue to survive for so long? Well, basically, one of the reasons is that the stromal tissue of the endometrium in endometriotic tissue, so if we go to this ectopic location and look at the endometrial tissue there, basically it will have a similar structure to the healthy endometrial tissue. It will have a stromal tissue and it will have an epithelial tissue. And basically, the stromal tissue of endometriotic tissue basically has far too higher expression of an enzyme called aromatase. Okay, now what's the significance of this? Well, basically, aromatase converts testosterone into estradiol. So basically, this allows the stromal tissue to create estradiol. Now, estradiol is the main form of estrogen. There are other forms of estrogen. There's estrone and estriol as well, but estradiol is the main form. And basically, estrogens are what maintain the endometrium, basically. So remember, in the time preceding the day 14 of the menstrual cycle, estrogen is being sent to the endometrium from the ovaries, basically, and this is what tells the endometrium to grow. So, the endometrial tissue within endometriotic bodies basically produces estrogen on its own and supports itself. Now, that is something that's abnormal. Normal endometrial tissue does not produce estrogen, basically. So this is something that's abnormal to the endometriotic tissue. Okay, so let me show you what aromatase does. So it converts testosterone into estradiol. So I'll show you the structure of testosterone and then I'll show you the structure of estradiol. And then we'll discuss aromatase inhibitors, which are an effective treatment for endometriosis by blocking this self-sustainability of the endometrial tissue within the endometriotic body. Okay, so basically testosterone is a steroid, so it has these characteristic 4 carbon rings that all steroid structures have. So 1, 2, 3, and then we'll have a 5 carbon structure here, like so. Okay, and then testosterone has a carbonyl group here, so it's not a sterol. Instead, it has a carbonyl group there rather than an alcohol group. You then have a double bond here, a methyl group coming off here, a methyl group coming off here, and then an alcohol group coming off up here. So that's the structure of testosterone. Now, aromatase is going to convert testosterone into estradiol. So let me now show you the structure of estradiol. Now, estradiol, as the name suggests, is in fact a sterol. It does have an alcohol group. And the reason it's called estradiol is that it has 2 alcohol groups, one up here and the other in the sterol position. So if you have an alcohol group off the steroid structure on this carbon specifically here, you're called a sterol. Okay, so let me show you the structure. So again, we'll have these 4 carbon rings, 1, 2, 3 and 4. So here's another one, and here's the 4th one, like so. Okay, and then you've lost this methyl group here, and you've converted this from a carbon ring where you only have 1 double bond to a carbon ring where you have 3 double bonds, and you have alternating single and double bonds, so it's become a benzene ring, and you also have this alcohol group coming off here. Okay, and then you still have this methyl group up here, and you still have this alcohol group up here. Okay, so this then is estradiol, and it's the main form of estrogen. And I should just say, I'm using the British English spelling of estrogen, which is frankly just silly, but it's the one that I've been brought up with, so I use it. But obviously the American English spelling of estrogen doesn't have the silly O there. It's just estrogen like that. And of course estradiol again would just be estradiol like so. Now there are other forms of estrogen other than just estradiol. There's also, I'll just put these here, there's also estriol, and you can take the O off if you wish, and then there's the estrone as well. Okay, so there are three main forms of estrogen: estradiol, estriol, and estrone. Estradiol is the main form, this form here. Okay, so now the endometrial tissue in these endometriotic bodies is capable of converting testosterone into estradiol. Estradiol will then support the endometrial tissue of the endometriotic body, and hence the endometriotic tissue becomes self-sustainable. So this is how it maintains itself for such a long period of time. Now, of course, if you're bringing in a new piece of tissue somewhere, whether it's into the ovaries, into the uterine ligament, into the rectovaginal septum, basically, what's going to have to happen? You're going to have to get a new blood vessel network that's going to supply that tissue. If the tissue doesn't have any blood vessels, it's going to become necrotic, it's going to become hypoxic, and it will die. Okay, so a very important part of endometriosis and why it's within this playlist at all is the importance of angiogenesis. So when the endometrial tissue moves to that new ectopic location, it's going to have to set up angiogenesis, basically. You're going to need to get blood vessels moving into the endometrial tissue to supply it with oxygen. So what will happen is if we show the endometrial tissue arriving, so let's say this is the endometrial tissue here, and it's just been blotted in on the new tissue, the new location here. Okay, it's now going to become hypoxic. It will then start releasing vascular endothelial growth factor, specifically vascular endothelial growth factor of the type A. So there are many different types of vascular endothelial growth factor. VEGF-A is the main form which is involved in hypoxia-induced angiogenesis. So this stands for vascular is the V, E is for endothelial, and then the GF is for growth factor, VEGF, and this is VEGF-A. Okay, right, so the vascular endothelial growth factor A will be released from this new piece of endometrial tissue, and what that will trigger is it will trigger angiogenesis. Now there are two main forms of angiogenesis. There is what's known as sprouting angiogenesis, and basically this is when a blood vessel, let's show it here, produces a new sprout which grows towards the angiogenic center, the center which is releasing vascular endothelial growth factor A. So let's say this is the angiogenic center here. What will happen is you'll produce a sprout off the side of this blood vessel that will grow towards the angiogenic center. Now if you have multiple blood vessels in the area, which of course you will, you might have another one which will also produce a sprout which will grow towards the angiogenic center. Now when those two sprouts meet at the angiogenic center, they'll then fuse, and you'll have a nice new connection between these two separate blood vessels, and that new connection will provide oxygen and nutrients to the endometriotic tissue. Okay, there is also a second type of angiogenesis which is much less well understood, okay, which is called intersusceptive angiogenesis or splitting angiogenesis. Now I should just mention it because it's also triggered by vascular endothelial growth factor A, okay, and basically what happens in intersusceptive or splitting angiogenesis is that you go from having one blood vessel and it basically splits into two separate blood vessels. So let me show you this here. Okay, so this middle portion is going to split into two separate blood vessels like so. So we now have two separate lumens. The blood can go this way or it can go this way like so. Okay, so you have these two forms of angiogenesis, sprouting and intussusceptive / splitting angiogenesis. Clearly in this case it's going to be sprouting angiogenesis that we're more interested in. We're more interested in sprouts growing into the endometriotic tissue and supplying it with oxygen. So this is the big thing at the moment, that people are looking into the treatment of endometriosis, as to whether if we inhibited angiogenesis we would stop the formation of these ectopic endometrial tissues, basically, because even if the endometrial tissue did move to some ectopic location, it wouldn't actually be able to take hold of that location. It wouldn't be able to live there, because if it didn't get angiogenesis occurring, if it didn't get these blood vessels growing into it, then it would get no nutrient supply, and therefore it would die, basically. Okay, so angiotherapy is a hopeful new potential treatment for endometriosis. Okay, right. So let's now just talk about the main symptoms of endometriosis then. And the main symptom is really just pain, and more pain. Okay, so why are endometriotic tissues so painful? Well, basically, they have an extremely high production of something known as prostaglandin E2, PGE2, which basically sensitizes neurons and makes them respond to much lower thresholds of pain. Okay, so PGE2 is short for prostaglandin E2. Okay, and this is the basis of the use of COX inhibitors, non-steroidal anti-inflammatory drugs, for the treatment of endometriosis. So basically, in the production of prostaglandin E2, you start off with arachidonic acid, okay? And then arachidonic acid is acted upon by cyclooxygenase enzymes, okay? And it will be converted into something called prostaglandin PG and then G2, and it will then be converted further by the same enzyme into prostaglandin H2. Now, these two reactions are so important that they have their own names. So the conversion of arachidonic acid into prostaglandin G2 is called the and then they put a dash between them, cyclooxygenase reaction. Okay? And then the conversion of prostaglandin G2 into prostaglandin H2 is then called the peroxidase reaction. Okay, and they're both catalyzed by cyclooxygenase enzymes. Now, there are two main forms of cyclooxygenase enzymes. Okay, there is cyclooxygenase, or COX as it's abbreviated to. So COX is short for cyclo is the C, and then the ox is for oxygenase. Okay, so there are two forms of cyclooxygenase enzymes. They think there could be another one, basically, but that one's still putative. Okay, and the main two forms are COX-1, cyclooxygenase 1, and COX-2, cyclooxygenase 2. Now, COX-1 is the one that is more constitutively expressed. You find it in tissues all over the body, basically. And it's very, very slow at catalyzing this reaction. It does it, but it does it slowly. COX-2 is one that is usually upregulated at sites of inflammation, okay, and it is fantastic at catalyzing this reaction. It does it at a speed that dwarfs the pathetic little contribution of cyclooxygenase 1. Now, in these endometriotic tissues, you have hugely upregulated cyclooxygenase 2, basically, and this means that you get a huge amount of arachidonic acid being converted into prostaglandin H2. Now, prostaglandin H2 can then be converted into prostaglandin E2 by an enzyme that's cunningly called prostaglandin E2 synthase, okay? And prostaglandin E2 then sensitizes neurons. It doesn't cause pain itself. What it does is it means that the threshold for a pain neuron to fire is hugely reduced, okay? So, for instance, if you go in the shower, okay, in fact, I'll tell a full story. Let's say you go in the shower, okay, and usually you can have the water on quite hot and it doesn't hurt you. It feels pleasant, okay? It doesn't activate your pain neurons. If you go out and lie on a beach all day, and with no sun cream on, you will get sunburnt. Okay, what happens is the skin gets horrendously damaged, you produce loads of prostaglandin E2 in the skin. This sensitizes all of the pain neurons so that they will now fire in response to lower grade stimuli than they usually would. So when you go in the shower at a normal temperature, it feels horrendously painful. Okay, and that's because all of the pain neurons are firing at a lower stimulus. Of course, if you put the shower too hot without being sunburnt, your pain neurons would eventually fire, okay, and it would be ouch. But when you've had some sort of damage to your skin, for instance sunburn, the neurons will get sensitized so that the stimulus that causes the activation of the pain neurons is a lower intensity. It basically means that the pain neurons will fire to a lower intensity stimulus. Okay, so it's basically leads to a huge amount of pain, basically. Okay, and this is actually the basis of the use of cyclooxygenase inhibitors in treating not only endometriosis, but in fact any sort of pain, basically. Wherever you have prostaglandin E2 produced, you end up with a lot of pain, basically. And cyclooxygenase inhibitors will stop the production of prostaglandin E2. That's the general principle of how NSAIDs have analgesic effects. And since this is occurring in endometriosis, this is why COX inhibitors, or non-steroidal anti-inflammatory drugs, are effective in treating the pain associated with endometriosis. So you can block these COX enzymes through a class of drugs known as NSAIDs. Okay, and NSAID stands for non-steroidal. The N is for non, the S is for steroidal. Okay, and then the AI is for anti-inflammatory, and then the D is for drugs. So these are the non-steroidal anti-inflammatory drugs. Okay, and you can have non-steroidal anti-inflammatory drugs which specifically block COX-2, and you can also have the ones which are non-selective. So we'll start with the non-selective ones, because these are the ones you have actually heard of. Okay, these are the ones which you will have taken before in your life. So the non-selective ones block both COX-1 and COX-2. Okay, so we have some very famous drugs here. So aspirin is the most famous example. Ibuprofen is probably the next most famous example. Okay, another very famous drug is indomethacin. Okay, so all of these three drugs are non-steroidal anti-inflammatory drugs which inhibit both COX-1 and COX-2. Okay, now there is problems with doing that. You will be aware that aspirin and ibuprofen have horrendous gastrointestinal side effects if you take too much of them. Okay, and the reason for that is that COX-1 is actually very important in controlling stomach acid pH, and when you inhibit it, it can lead to the stomach acid becoming too acidic, basically, which can lead to gastrointestinal bleeding. Okay, so we therefore sought drugs which did not block COX-1, because that's the one, remember, that is mainly constitutively expressed in tissues around the body. Certainly it's the one that's expressed within the gastric mucosa. And only block COX-2, because remember, this is the one that's hugely upregulated at inflamed areas. This is the one that will be hugely upregulated within our endometriotic tissue. Okay, so people sought COX-2 selective drugs, and we got them. The problem is they are a little bit of a disappointment. Okay, so they are still very effective analgesics. The problem is that the theory that COX-2 wasn't constitutively expressed anywhere wasn't quite true. Okay, and because COX-2 is constitutively expressed in the endothelium, and the endothelium uses it to produce prostacyclin, COX-2 selective inhibitors can actually promote myocardial infarction. Okay, so they're not widely used drugs. But an example of a drug within this class is celecoxib. Okay, there's another one that's approved in Europe, but I don't think is approved in America, known as etoricoxib. And there was a very famous COX-2 selective drug called rofecoxib, and the brand name for this was Vioxx. Okay, and this had to be withdrawn from the market. It was withdrawn from the market, I believe, in 2004 because it was basically causing heart attack in people who took it. Okay, so it was not a good drug. So it's been withdrawn now, so that's no longer available. And you might ask, well, why do celecoxib and atoricoxib not trigger myocardial infarction if rofecoxib does the same thing as them? Well, the reason is these are slightly less COX-2 selective than rofecoxib. Rofecoxib was a fantastic drug. It was very, very selective for COX-2 over COX-1, whereas celecoxib and atoricoxib are much less selective. They still block a bit of COX-1, basically, more so than rofecoxib did, and that balance is why they don't cause myocardial infarction, whereas rofecoxib does. So let me just elaborate a bit on that a bit more. So basically, COX-2 is expressed within endothelial cells, okay, and they are using it to produce prostaglandin H2 from arachidonic acid, so just this pathway that we've already discussed. And then what do they make from the prostaglandin H2? Well, endothelial cells usually make prostaglandin I2. Okay, so endothelial cells are usually using COX-2 to produce prostaglandin I2. And when you just block COX-2, you block the production of prostaglandin I2. And you might say, well, hang on, that's going to be the same for aspirin, ibuprofen, indomethacin, celecoxib, atoricoxib. So they're all going to stop the production of prostacyclin. So if it's the stopping of the production of prostacyclin that causes MI, why on earth don't they all cause heart attack? Well, the reason is that basically there is this balance between prostacyclin or prostaglandin I2 and another thing called thromboxane A2. Okay, so TXA2. So this is thromboxane A2. Okay, and thromboxane A2 is produced by platelets. Okay, so this is a bit big for a platelet, but I apologize for that. Okay, and basically thromboxane A2 is also just one step off prostaglandin H2, so you can convert prostaglandin H2 into thromboxane A2. So again, the platelets are taking arachidonic acid, they're converting it into prostaglandin H2, which they're then converting into thromboxane A2, and they are converting the arachidonic acid into prostaglandin H2 using COX-1. Okay, so basically, if you use a non-selective COX inhibitor, you knock out both of these, you stop the production of both prostacyclin and thromboxane A2, and then that doesn't cause MI. And let me now explain why. Because basically these two things, prostacyclin and thromboxane A2, they do the absolute opposite of one another. Okay? Prostaglandin I2 causes relaxation of vascular smooth muscle cells, so it causes vasodilatation, whereas thromboxane A2 causes contraction of smooth muscle cells around blood vessels and therefore causes vasoconstriction. Okay, so there is always a balance between them. If you up the level of thromboxane A2 within the blood, you will get vasoconstriction. If you up the level of prostacyclin relative to thromboxane A2 within the blood, you'll get relaxation. Okay, so here's the thing. If you just block COX-2 and don't block COX-1, then you lower prostacyclin without lowering thromboxane A2. So the relative proportions of prostacyclin and thromboxane A2 that you have is hugely favored towards thromboxane A2. That means that thromboxane A2 is no longer counteracted by the prostacyclin. Usually there's a balance between the two. Prostacyclin is screaming at the smooth muscle cells to relax, whilst thromboxane A2 is screaming contract, contract, contract. And usually it just sort of ignores both of them, basically. It says, you're cancelling each other out, I don't care. However, once the prostacyclin is no longer there, the thromboxane A2 gets its way, and it basically makes all of your blood vessels contract. And when this happens in the coronary arteries that supply the heart, you can get basically the blockage of blood delivery to certain portions of the myocardium, and that can then trigger myocardial infarction. Okay, whereas if you block both of them, if you use a non-selective COX inhibitor and block both of them, then you reduce both of them down, and therefore it doesn't matter that that prostacyclin's gone down, because if thromboxane A2 is neither there anymore, then it's not going to cause the contraction of the smooth muscle cells surrounding the blood vessels, and therefore it's not going to trigger the myocardial infarction. So that is why non-selective COX inhibitors do not cause MI, whereas the selective ones carry that risk. And the more selective you are, the more you're going to reduce this compared to this, and therefore the more is your risk of producing myocardial infarction. And rofecoxib was just too selective, basically. It was too good at being just a selective COX-2 inhibitor. As a pharmacological agent, it was a fantastic drug. It was a fantastic achievement in pharmacology. As far as actually clinically being useful, it was a awful drug. Okay, and I actually know someone, one of my pharmacology teachers, actually her father took this drug and died of a heart attack whilst on it. So I have connections with this. Okay, so not a nice drug. Okay, so not used. I'm going to put a great big cross through that. But NSAIDs are used to treat endometriosis. Okay, right, and that's the basis of their treatment in endometriosis, that they will stop the production of prostaglandin E2, and therefore they'll stop the sensitization of neurons and stop the excessive pelvic pain that people feel when they have these endometriotic tissues. Okay, so we'll just then talk about the other symptoms. I'll just give you two nice big words that you can add to your vocabulary. You also get what's called dyspareunia, okay? So another symptom of endometriosis is dyspareunia, spelt like so. And this basically means pain during sex, basically. So whilst having sex, you feel pain, okay, if you're suffering from endometriosis. You also get dysmenorrhea, okay? And this means pain during menstruation, and of course you get pain anyway during menstruation, but excessive pain during menstruation is what is meant by dysmenorrhea. Okay, so those are two other symptoms that are felt during endometriosis. So to summarize, endometriosis is abnormal positions of endometrial tissue. You get basically endometrial tissue living happily at some bizarre location, okay? Not too far away from the female reproductive system, as we've seen. You don't end up with endometrial tissue growing in the brain, for instance, okay? And basically the endometrial tissue is sustained there because it has this abnormal property where it has very high expression of the aromatase enzyme, which converts testosterone into estradiol, and estrogens, as we know, are what sustain endometrial tissue. So it basically has this self-sustainability. Also, very importantly, it sets up angiogenesis, so loads of new blood vessels are going to grow into the endometriotic tissue, and this could potentially be a future direction in which treatment goes. If we can block the angiogenesis, then we can block endometriosis. Okay, and the main symptoms are pain when you have sex, dyspareunia, pain when during menstruation, excessive pain during menstruation, dysmenorrhea, and pelvic pain just all the time, basically. And one of the main ways we can treat this is using COX inhibitors. And I just want to mention one more drug, actually, which I promised to talk to you about. Also, you might think, the COX inhibitors are great. They will stop the pain, or at least reduce it hugely. But they don't actually treat the underlying cause. Angiotherapy is a great prospect, but it's not actually realized yet in the clinic. But there is a drug that is used in the clinic which potentially will actually strike at the cause rather than just treating the symptoms, and this is an aromatase inhibitor. Now, there are loads of aromatase inhibitors that can be used to treat endometriosis. The one that I'm going to give you the name of is anastrozole. Okay, so anastrozole blocks the aromatase enzyme. So basically the idea is that it will block the conversion of testosterone into estradiol. Now, as you can imagine, this drug would not be taken lightly because it's going to stop the synthesis of estradiol, basically. There are get-around routes. You can convert one of the other estrogens into estradiol, and you can synthesize the other estrogen from other means, but it's going to majorly affect the synthesis of estradiol, so there would be side effects to taking anastrozole, but as you can imagine, if you block aromatase, then you block the conversion of testosterone into estradiol within this endometriotic tissue, okay? And then the endometriotic tissue loses this major hormone that is sustaining it, basically. It loses its self-sustainability. So that's a final drug that I'd like to mention. Okay, so that now concludes our discussion of endometriosis.